Good evening, everyone. Basically, my fellow debatant agrees with me by saying that all patients should not be with hypogonadism in type 2 diabetes mellitus should not be tested for hypogonadism testosterone level, and all of them should not be treated. Basically, he agrees with me. And if you go through the major guidelines across the globe, they stated that in patients with type 2 diabetes mellitus, we should check for testosterone only when there is core symptoms of hypogonadism, namely three: erectile dysfunction, decreased libido, and absence of nocturnal penile tumescence. And if you go through the ADA guideline, ASA guideline, they highlighted we should test it when the body mass index is more than 30. Why? Because uh, actually, the low testosterone level is strongly related to insulin resistance and intra-abdominal fat. Presence of glycemia or duration of glycemia per se is not strongly correlated with the presence of hypogonadism. Now, what are the evidence of testosterone replacement therapy in patients with functional hypogonadism in our patients with type 2 diabetes mellitus? Regarding glycemic control, if we consider the Traverse trial, which has been mentioned, the largest trial ever done, CVOT trial comprising 5,000 individuals, the pre-diabetic individual who are treated with testosterone failed to show any progression from pre-diabetes to diabetes. And those patients who are diabetic, who are treated with testosterone therapy, there was no improvement in glycemic control. So where is the evidence of glucose control in the recently done this big, largest trial, where I say, with testosterone therapy? Regarding cardiovascular safety, yes, we have now cardiovascular safety data in terms of 3-point major adverse cardiac events from the Traverse trial. But the very trial is saying that there was very significantly rise of unexplained level of atrial fibrillation, unexplained acute kidney injury requiring intervention, and there is also higher incidence of venous thromboembolism from the very same study. So we should also take care into mind. Regarding prostate safety, yes, there is no significant signal of prostate malignancy with testosterone replacement therapy, but we know testosterone replacement therapy is absolutely contraindicated when in the presence of metastatic prostate cancer, in the presence of significant lower urinary tract symptoms, prostatic hyperplasia. And we, most importantly, we monitor them. We monitor them either through digital rectal examination according to some guideline, and of course with at least PSA. If PSA value is more than 4 nanogram per ml, we cannot start, or we should discontinue testosterone therapy. Now, one guideline is very funny that stated the digital rectal examination, if it is performed by an endocrinologist, could cause more harm than the benefit. It is easy to understand because we are not familiar with doing visual rectal examination, so it can take away the patient from you. Definitely, there is a connection between increased incidence of obstructive sleep apnea and testosterone replacement therapy because of the fluid retention, and there is a significant rise of hematocrit in several trials, including the here I presented the data of T4 trial. In T trial, there was 54% cases there was a rise of hematocrit. So these things has to be kept in mind. If you look at the quality of data, one of the most acclaimed proclaimed domain that testosterone replacement therapy actually increases the quality of data. If you look into the data objectively, you will find the level of increase in quality of data is only modest. And if you consider the mental health, the depression score is lowered only marginally. And I think the most important domain where the testosterone replacement therapy has a very good role is improving the sexual function. And where it increases the desire, libido definitely, but testosterone therapy often fails to improve the erectile dysfunction, because erectile dysfunction in type 2 diabetes mellitus is mostly because of other reasons than hypogonadism, like neuropathy, vasculopathy, etc. So basically, you ignite the fire, you rise the desire, but patient cannot perform. See the helplessness or irony here. And we have better options in treating erectile dysfunction. Studies have shown that in patients with type 2 diabetes mellitus, optimization of phosphodiesterase 5 inhibitor, independent of testosterone therapy, can improve the erectile dysfunction. Studies have also shown that phosphodiesterase therapy, when it is used in the optimized fashion, addition of testosterone therapy will provide a new marginal benefit. Now, it is recent that the post 5 year trial data for the T4DM trial had shown that some patients are can be showing some notion of addiction. So that has to be kept in mind. We need to trade with caution. As far as lives, and do I have any proposal for another aspect of doing this? Yes, I have, because Corona et al. Long ago have shown that more than 10% of body weight loss through any means by low calorie diet or bariatric surgery is associated with very significant rise of testosterone level to the physiologic range. And in that era of GLP-1 receptor analog, triple agonist, dual agonist, which can offer 20% or more weight loss, it is expected that the basic cause of functional hypogonadism, that is obesity, can be alleviated, and testosterone can naturally go up. We don't need to overtreat them with pushing testosterone in any means. Now, even if you treat the patient, always remember there are several options. There are short-acting esters, and there are fluctuations in the level, and you can see someday your patient is 0 and someday he is 0. And there are long-acting preparations like testosterone undecanoate. You see the volume of injection is very high, so there is extreme pain sometimes, and there could be chance of microembolization. And I hope you should definitely not feel good when you will see your partner is growing mustache or beard while transferring the testosterone gel from you to your partner. And there is of course problem with absorption with oral testosterone. So my concern is that testosterone is not an anti-diabetic medications. It is not an anti-diabetic agent. The primary modes of therapy in functional hypogonadism in type 2 diabetes mellitus is lifestyle modification, weight loss, and it should be used selectively only in patients with clinically and biochemically proven hypogonadism. Thank you.
Thank you.